students, good morning one and all. I am Dr. Kaarunya from the Department of Conservative Dentistry and Endodontics from Vinayaha Mission Sankaracharya Dental College, Salem. Today we are going to see on the topic endodontic mishaps. What is endodontic mishaps? It is nothing but the procedural errors that is iatrogenically created by the operator on the patient which affect the prognosis of the root canal treatment. Though we are doing the root canal treatment with utmost care, the endodontic mishaps rate is 5% to 34%. So, we can easily create a mishap, but managing it, identifying it is a big headache to the operator. So, careful prevention of the mishap is of utmost importance than creating it. In this presentation, we are going to see the classification and the types of the mishaps. What is the etiology of the mishap, how can we prevent it, and if the mishap happen, how can we manage it. So, coming to the classification of endodontic mishaps, according to Hingle, it is classified into 4 major classes. First is access cavity related mishaps, second is instrumentation related mishaps, third one is obturation related mishaps, and fourth one is miscellaneous. So, in this presentation, we can see each and every mishap one by one in detail. Access cavity related mishaps include treating the wrong tooth, missed canals, perforations, and instrumentation related mishaps includes ledge formation, perforation, canal blockage. And coming to the obturation related mishaps, it is overfilling, underfilling, nerve paresthesia and vertical tooth fracture. Other mishaps includes tissue emphysema, post-space perforation, irrigant related mishaps and instrument aspiration and ingestion. Let's see about the access related procedural errors. So, treating the wrong tooth. It is the most common practice when we apply a rubber dam. So, when a patient comes with a pain in a particular tooth, the operator accidentally places the rubber dam in the wrong tooth and open the incorrect tooth. So, what we can do in this procedure, we have to treat both the teeth, the one which have opened incorrectly and the other which has the symptoms. So, how you can prevent it? You can place a marker on the teeth to be treated, then you can place the rubber dam over it and then you can continue with the treatment. This mainly occurs due to inattention on the part of the dentist. Next is the missed canals. So, the most commonly we are missing canals due to the lack of knowledge of the anatomical variations by the operator, and also the accessory canals will be frequently missed. How you can prevent it? By using digital radiographs in various angulations. You can find an extra canal, you can use loops, magnification and illumination. Prevention. Correct access cavity preparation is of utmost importance for finding all the accessory canals. If a orifice is not in the midline, then we have to search for an extra canal in the opposite symmetry of the orifice present. Secondly, we can use dentinal map as a guidance for finding the missed canal. So, we can use DG16 Explorer and the pre-curved cave file for finding the missed canal. Next is the champagne bubble test. Here the sodium hypochlorite is placed in the pulpal chamber and a tiny bubble applies in the place of the orifice, and this helps to find the missed canal. Next is the slob rule. A canal, when it suddenly disappears when you move apically, this is the fast break. So, in such cases it means that there are multiple canals present in the same canal. It is divided into smaller canals. So, this can be identified by using slob rule. Here a radiograph can be taken from 2 or 3 angulation and it helps to identify the accessory canals. Next method for finding the missed canal is magnification and illumination. You can note the detection rate of MB2 canal with the naked eye is only 17%, but with the loops it is around 60 and more %, and with the microscope it is more than 70%. Next aid is the use of dyes for finding the extra canals. You can use methylene blue dye or the fluorescent dye for staining the extra canal and you can use it. Another accessory aid for finding the missed canal is the removal of calcifications by using ultrasonic tip or using long shank burr for removing the dentinal overhangings in the chamber. So, next mishap is the perforation. Perforation is nothing but the mechanical or pathological communication between the pulpal canal and the extra periodontal tissues that happens accidentally by the operator. So, iatrogenic perforations can occur at any level of the root canal, either in the coronal part, in the pulpal chamber, at the furcation area, at the coronal part of the root, middle and the apical part of the root. Perforation may result in injury to the periodontium. In turn, it results in inflammation, destruction of the periodontal fibers, bone resorption, granulomatous tissue formation, epithelial proliferation, breakdown of periodontium, and ultimately it results in tooth loss. Various factors affect the prognosis of root canal treatment after perforation. First is the initial damage to the periodontal tissue. Next is the size of the perforation. If the size is small, it has better prognosis than the larger size perforation. Next is the location of the perforation, where it is located. Apical perforation has higher success rate than the cervical perforations. Time lapse between the injury and the repair. Accessibility of the perforation also is a major factor affecting the prognosis. Then the biocompatibility of the reparative material used also affects the prognosis of the perforation repair. So, what are the causes of perforation? First is the lack of knowledge regarding the anatomical variations in a tooth. Second is the misalignment of the burr. As you can see in this picture, the burr is placed in this direction, but the root canal anatomy is in this direction. So, this creates unwanted perforation in the cervical region. Similarly, see in this image, the burr is angulated in a wrong direction than the root canal direction, and hence it causes coronal perforation. So, next is the attempt to locate and calcified canals. The burr is angulated in a wrong direction than the direction of the calcified canal. Next, the cervical portion of the canal can be easily perforated with the inadvertent use of GG drills there, because it has the very minor dimension. Next is the strip perforation that can occur in a curved canal at the mid-level root. So, this occurs in a curved canal due to straightening of the use of files. Next is post-space preparation can also result in perforation whenever there is misdirected angulations of the burr. Again, the apical perforation can also occur when a ledge has been formed during the initial instrumentation. So, how can you diagnose a perforation? First, there will be a copious bleeding from the canal, which signifies a perforation has occurred. Then, whenever a paper point is placed inside the canal, a red bleeding will occur at the paper point. This indicates perforation. Electronics apex locator can be used to identify the perforation. Patient may also complain of pain whenever the instrument impinges the periodontal tissue. Next, multiple angulator radiographs can be used in identifying the perforations at various levels. Even the strip perforation occurring at the midway of the root can be identified with the CBCT sections. So, how can we repair a perforation? First, when the perforation happens in the crown or furcation area, what you will do is first locate all the root canals, then stop the profuse bleeding using colgate or something. Then the defect is cleaned. If the surrounding bone is closely adapted to the defect, then no osseous matrix will be required. But if the perforation is associated with large osseous defect, then an extraneous bone matrix will be required for the repair. What are the materials that can be used for perforation repair? That includes MTA, glass ionomer, biodentin, super EBA, and so on. So, the same perforation, when it appears in the middle third of the root, how can we rectify it? First, here the perforation has occurred. Now, a file has been placed to the entire length of the defect. Then MTA is carried into the place of the defect. Then the tip of the file is vibrated with ultrasonic tip so that the MTA settles in the defect. After filling the defect, the remaining portion of the canal is filled with catapecia. So likewise, the middle perforation can be rectified. Then coming to the apical perforations. Apical perforation, our primary aim is to find the canal that is not negotiated. Once the canal is negotiated, you have to fill the canal either with GP, that is catapecia, or with MTA obturation. In all cases, you cannot treat the apical perforation orthogradally. So you should be using apical surgery for cutting the apical 3 mm of the perforation. So sometimes it may also require extraction of the teeth. So how can you prevent perforation? First, you should have a thorough knowledge of the canal what you are going to treat. Then using smaller flexible files for curved canals, not skipping the file sizes, recapitulation with smaller size files during the procedure, maintaining the instrument within the confines of the working length without going beyond the working length, anti-curvature filing techniques. You should avoid overuse of Gates Glidden drill, avoid your overuse of chelating agents like EDTA, and copious irrigation with irrigants like sodium hypochlorite or chlorhexidine. So these can be followed for preventing perforations. Next endodontic mishap is crown fracture. So whenever we are inadvertently using the burrs, a small crack may occur in the tooth. This may ultimately result in the fracture of the crown. These pre-existent infections can be identified when we remove the existing restoration from the tooth. So when these infections become enlarged, it will cause the fracture of the crown. So such crowns with infections should be supported with some temporary crowns during the endodontic treatment. So not all the times this teeth with crown fractures can be saved. Most of the times it has to be extracted. So such crown infractions can spread to the root and may cause vertical root fractures. Most probably these crown fractures are having very poor prognosis. Next, coming to the instrument related procedural errors. First is a ledge. Ledge is nothing but an iatrogenically created irregularity in the root canal that impedes the access of the instruments to the apex, resulting in insufficient instrumentation and incomplete obturation. So how can you prevent ledges? First, pre-curving the 3 to 4 mm of the apical part of the file according to the curvature of the root canal that you are going to treat. Second, you have to use sequential file sizes. You should avoid skipping the file sizes in between. Rotating the file inside the canal should be avoided. So what are the causes of ledges? First, not obtaining a straight line access to the root canal, that is, not extending the access cavity sufficiently to form a straight line access to the canal. Secondly, complete loss of control of the instrument can cause ledges. Third, incorrect assessment of the root canal direction. Next is the incorrect root canal length determination, forcing and driving the instrument into the canal, not curving the stainless steel instruments for a curved canal, and using the instruments in the non-sequential order. So these are the causes of ledge formation. So how can you recognize whether you have created a ledge or not? First, the root canal file cannot be inserted till the tip of the canal, that is, the full working length you cannot negotiate. Second, loss of normal tactile sensation of the tip will be found. Next, radiographically, the instrument point appears directed away from the lumen of the canal. So how can you correct a ledge? You should use a small number file like number 10 or 15 number file. You have to pre-curve the bend. You have to insert carefully into the canal so that the pre-curved end is facing away from the ledge, that is, it is facing the intact canal surface. You have to penetrate the file carefully into the canal. The silicone stopper can be used to maintain the direction of the file in the canal. So next, coming to the endodontic mishap, zipping, transportation and creation of elbow. What is zipping? Zipping or elliptication. It occurs in the portion of the canal apical to the curvature, where the canal wall structure opposite to the curve tend to straighten the canal curvature. So this is zipping. So what is elbow? When a curve, pre-curved or straight, when it is rotated inside the canal, so what will happen? A biomechanical defect known as elbow forms coronally to the elliptically shaped apical sheet. So this is elliptically placed apical sheet. So apical to this elbow will be created. Next is the transportation. Transportation refers to the transportation or transposition of the apical portion of the apical foramen occurs when an overextended file transports the outer wall of the apical foramen. So what are the causes of these zipping, elbow and transportation? Failure to pre-curve the files, forcing and rotating the instrument into the canals, and use of larger stiff files without pre-curving. These are the causes of elbow. So how can you prevent it? Pre-curve the file, use incremental filing technique, avoid rotating the files inside the canal, use flexible files. So these defects can be managed with the help of thermoplasticized catabacha technique. That is, since the apical seal is not proper, heat can be used and directly the catabacha can be condensed inside the canal. Apical seal will not be good since it does not have a continuous tapering preparation in the apex. Next endodontic mishap is the canal blockage. Frequently, the canals what we are instrumenting may get blocked iatrogenically with dentinal strips, cotton pellets, paper points, fractured instruments, packing of dentin chips, tissue debris and restorative materials. Canal blockage can be prevented with the help of copious irrigation, chelating agents, ultrasonics, sequential use of files and recapitulation. Next endodontic mishap is the file separation. File separation is an unavoidable endodontic mishap. So repeated use of a single file can cause separation of the file into the canal, or whenever the stress in the file is increased than the optimum stress, the file may get separated inside the canal. The main cause of file separation is fatigue that acts as a result of a combination of torsional stress and the cyclic loading in the file. So what are the causes of instrument breakage? When a file gets locked inside the dentinal walls, whenever the file is overloaded inside the canal, whenever the flutes on the file is unwinded and even after that we are using it. So this type of failure is called torsional fatigue. So using a previously stressed instrument, placing exaggerated bends on the instrument in the name of pre-curving and forcing a file into the canal before it is opened sufficiently, and forcing a file into the canal before it has been opened sufficiently with the previous smaller file. So how can you prevent a file separation? First, we can use a crown down technique, that is, the coronal portion of the canal is prepared first, then the middle, then the apical portion. You should prevent accumulation of debris inside the canal so that the file will not go and lock inside the debris and get separated. Next, an adequate glide path should be created for the smooth gliding of the file inside the canal. Next, never use excessive pressure on the handpiece so that the instrument will be separated inside the canal. So whenever that separation happens, so what can you do? There are 4 approaches of treatment. First, you can either remove the instrument or you can bypass the instrument. You can use the separated instrument as a part of the obturation system. Then fourth is the extraction of the teeth. If the instrument gets beyond the apex, then surgery should be done. If nothing works out, finally is the extraction of the teeth. Whenever an instrument is separated, so many things you have to keep in mind while treating the teeth. Those essential prerequisites includes dental operating microscope, ultrasonics and illumination. So whenever an instrument is fractured coronally, you can use Sligrit's plier or small hemostat, that is mosquito forceps. The tip can be grasped with the help of mosquito forceps and a slight anti-counterclockwise direction is given to the forceps and the file can be removed. So whenever the instrument is fractured below the orifice navel, you can either bypass it or you can either remove the file. So how can you bypass it? What is the bypassing technique? First, you should use a smaller size file, number 6, 8 or 10. You have to pre-curve the tip 2 to 3 mm. You have to create a small ledge in the side of the instrument, that is file that is broken. So once a catch has been obtained, you should use small in and out motion so that you can create a path to the apex. So after creating a path, a larger size file can be used to enlarge the cavity, and finally irrigants will be reaching the apex, and this is the bypass technique. Second, you can also remove the separated instrument, that is retrieve the separated instrument. So there are various methods that can be used for retrieving the instrument from the kennel. So what are the methods? First is the ultrasonic method. So first, a staging platform is created around the file that is separated in the kennel. For creating a staging platform, you can modify a GG drill, that is you can cut the head of the GG drill and create a circumferential staging platform. So this is shown in the figure. A GG drill head is cut, and this part can be used for creating a staging platform around the separated file. Sometimes an ultrasonic instrument can also be used for creating staging platform, but often it does not have space between the separated instrument and the dentin. So see this figure. As you can see, there is a separated instrument inside the kennel. First, you have to enlarge the kennel so that the instrument can be retrieved easily outside this kennel. First, a staging platform is created around the 1 to 2 mm of the separated instrument. It is created in the counterclockwise direction using modified GG drills or ultrasonic tip. Now, the counterclockwise direction is used with the help of ultrasonic tip at the end of the separated instrument so that this instrument will be retrieved in the coronal direction. Next is the modified needle technique. In this technique, the needle is cut at the bevel end and the opposite end of the wire is passed, creating a wire loop. This wire loop encroaches the separated instrument and it is tightened, and the separated instrument can be removed out of the kennel. Here, H-file can also be used to assist in the locking of this separated instrument, and it can be removed. Next method of instrument retrieval is extractor system, that is rod end extractor system. It consists of one burr and 3 extraction devices. So the burr is very conservative and it removes minimal amount of dentin around the separated instrument. Next, the extractor, any one of the extractor according to the size can be used. So this surrounds the obstruction with small prongs that can be tightened on the object, enabling its removal. So the prognosis of the root canal treatment will not be affected if the instrument can be bypassed. But when the surgery is needed, the prognosis is very much affected, that is poor prognosis. So how can you prevent instrument separation? You can prevent it by careful handling of the instruments. Discard the stressed instruments. You should not use any instrument more than 4 to 5 times. You should use small number of instruments like number 6, 8 and 10 only once. Sequential instrumentation only after a file gets loosened, then only you have to increase the file size. Then coming to the obturation related mishaps. First is overfilling. Overfilling mainly occurs due to over-instrumentation of the kennel. Overfilling may cause foreign body reaction. Sometimes the extruded gutta may go and impinge into the periapical bone, sinus, nerve bundles and so on. Whenever it is impinging on the nerve bundles, it may create pressure on the neurovascular bundle and may even result in paresthesia. Next is underfilling. It may occur due to improper working length determination whenever the kennel is blocked due to some dentinal debris, and also due to inadequate irrigation and recapsulation procedures. So, what is the consequence of underfilling? The apical portion of the kennel will not be disinfected properly, and this may result in secondary infection, and in turn it may be needing retreatment. So how can you correct this overfilling and underfilling? Underfilling, you can remove the existing restoration, you can again redo the BMP procedures and do retreatment of the canal. For overfilling, it is not always possible to treat it orthogradally. So sometimes it may require surgery and this has poor prognosis. Next comes nerve paresthesia. Whenever we do over instrumentation or whenever there is over obturation, there may be some pressure occurring on the neurovascular bundle and this will create nerve paresthesia. This nerve paresthesia may be transient or permanent. So how to manage this? First, you can prevent it. Second, you should not do any intervention, but you should keep on observing what it is needed. Third is, if corticosteroids is required, you can give corticosteroids and treat the patient. Next comes the vertical root fractures. It can occur at any stage like instrumentation, post-space preparation or obturation stage. Both lateral condensation and warm condensation exerts pressure on the root canal surface and both can cause vertical root fractures. So how can you recognize a vertical root fracture in a radiograph? Tear-shaped or J-shaped radiolucency will be present. A recently developed deep periodontal pocket will be there in a particular tooth, or a crunching sound will be there in the root. That is a clear indicator of a vertical root fracture. So you can confirm a vertical root fracture with the help of periodontal probing, dyes, bite test, trans-illumination test and also exploratory surgery to visualize the fracture line. So what is the treatment of vertical root fracture? It is nothing but extraction. So you can prevent such vertical root fracture by avoiding over preparation of the canals and by using less forceful obturation techniques. Coming to the miscellaneous endodontic mishaps. First is the irrigant related mishaps. The most common is the sodium hypochlorite accident. So whenever the irrigant is forced into the periradicular tissues, it will cause swelling, pain, interstitial hemorrhage and ecchymosis. This is the sign of sodium hypochlorite accident. So whenever an irrigant is forcibly injected into the periradicular tissues, such accidents happen. Symptoms depend on the type of the solution used, concentration and the amount of exposure that the irrigant is exposed to the radicular tissues. Management of such irrigant related accidents include use of copious irrigation in the canal to dilute the amount of irrigant that is extruded into the periradicular tissues. Next, use of antibiotics in addition to analgesics, use of steroids if necessary, use of ice packs and hospitalization whenever required. So such irrigant related accidents can be prevented with the help of passive irrigation. That is, the needle should not be wedged into the canal and the irrigant should not be forced into the periradicular tissues. Long-term effects include paresthesia, scarring and muscle weakness. Next, iatrogenic procedural error is the tissue emphysema. Tissue emphysema is nothing but the passage and collection of air in the facial planes and tissue spaces. So the main cause is that the compressed air, whenever it is being forced into the tissue spaces, it gets collected in the tissue spaces. So this commonly occurs in two ways. Either during root canal preparation, whenever we want to dry the canal, a blast of air is injected into the cavity, or while using air from high-speed drill in apical surgical procedures. Tissue emphysema symptoms include rapid swelling, erythema and crepitus. It remains in the subcutaneous connective tissue and usually does not spread to the deep anatomic spaces. So whenever the air migrates into the neck region, it causes respiratory difficulty, and whenever it enters into the mediastinum, it can even result in death. So you can prevent such tissue emphysema by following these methods. First, use of paper points to dry the canals instead of using air pressure to blow the canal. Second, whenever the air syringe is used, horizontal positioning over the access opening must be followed to dry the canal. In surgical procedures, apical access can be established with the help of slow speed or high speed handpiece that do not direct jets of air into the surgical slides. These three methods will prevent tissue emphysema. The last endodontic mishap is instrument aspiration and ingestion. Whenever a rubber dam is not used, the endodontic instrument can be easily swallowed by the patient. It can either enter the stomach or the lungs. That is, it can either ingested or get aspirated. As an immediate measure, we have to take radiograph of the chest and the abdomen. Whenever you are doing endodontic procedures, you can tie a floss in the clamp while placing the rubber dam to prevent accidental swallow of the rubber dam clamp. To conclude with, what our mind does not know, our eyes do not see it. A thorough knowledge of the subject is essential to prevent such endodontic procedural errors. Making an error is very easy, but managing it is very difficult. I hope you all students will have a thorough knowledge of the etiological factors, how to prevent it, how to recognize a procedural error, and how to manage it. I would like to conclude with the statement, preservation of that which remains is of utmost importance than the replacement of that which has been lost. Thank you all.